good evening, and thank you for joining us. If you don't know who I am by now, I don't know. This is Ellis. My name is Ellis Dean, and I am the Director of Digital Programming here at BlackDoctor.org. And we are, if you just saw me, I was just on with Dr. William Cooper talking everything about heart health. And so this is part of our heart health series. This is February 28th. It's the end of the month. This is end of Heart Health Awareness Month. It's also the end of Black History Month. So this is coinciding, but heart health is year round. So we want to give you, on the last day of the month, we're going to give you, last but certainly not least, we're going to give you some great information that you need to have about heart health. And so to this program is dedicated to Black women. So we know Black women and heart health. Heart disease is the number one killer of Black women, and most people don't know that. If you ask, I bet if you went down the street and asked somebody, they wouldn't be able to tell you the number one killer for Black women, and they probably wouldn't be. They'd probably say something like breast cancer or something else, diabetes or hypertension, but I don't think people would say heart health. And we have to recognize that this is number one. So what are we doing to prevent it? What are we doing to improve our heart health? And what are we doing to get Black women to know those things that they should know to keep their heart healthy? So I have some wonderful friends with us with this evening. We've got Dr. K. Y'all know Dr. Special. I call her Special K. Dr. K with Health and Wellness. And we have Dr. Myrna Alexander Nickens, and she is here to help us and get all of the information that we need tonight. So I'm going to shut up. I just was talking for an hour. I'm going to shut up. Dr. K, you got the floor.
Good evening, and I want to thank Dr. Nickens for volunteering to speak to us. I absolutely, I'm thrilled to meet you on this day of Heart Health Month and Black History. So I'm going to say a little history about you. Number one, yes, you. And that is that Dr. Nickens happens to be and is the first interventional cardiologist to practice in the state of Mississippi. She is a full professor at the University of Jackson Medical Center. Let me just tell you, she went to medical school at Meharry, and then she went to Meharry College. And we also know that she did her internship, her residency at Henry Ford in Detroit.
Yes.
So let me just say, this sister is tough. Okay.
This is bless you, Mississippi and Detroit.
Yes. And it's no small feat.
The Great Migration, okay.
And so it's no small feat that she is an interventional cardiologist. I know it's kind of like, oh, well, what does that mean? But let me tell you, there are a number of steps to make it to that height in her specialty. And she is the creme de la creme of the cardiologists, as I would say. Just the wisdom and the knowledge. And we don't want to minimize the trailblazing that you've done. And I'd like for you to share some of that story with us, Dr. Nickens, before we get into cardiology and heart health. Please tell us about your journey to become an interventional cardiologist. That's important. For all the little Black girls out there listening, I want to give you a minute to tell them something about what it takes to do what you've done.
Well, I really don't like to talk about that, but it was a journey, and it was a great journey, really. I loved it. I wanted to be a physician since I was 6 years old and didn't know anything else but my physician at home, which was in Biloxi, Mississippi, Dr. Gilbert Mason. He was one of the people that inspired me to be a physician. But when I went to Meharry, was where I decided to do cardiology and moved from Meharry in Nashville up to Detroit and met a great group of people there, and they nurtured me, and I loved it. Spent 13 years there. I thought about it at the time. One of my professors would say, "Hey, Myrna, don't you want to do women and heart disease stuff?" Now, this was a long time ago, okay, before you were even thinking about medicine, Kendra. I said, oh, that's women stuff. I don't want to do that. Okay, I want to do what the guys are doing. And so I I did a fellowship in interventional cardiology, but there are more women doing interventional cardiology now. I was the first female interventional cardiologist, not the first cardiologist, interventional cardiologist in Mississippi, which does not say a lot to me. That means that we need more, because if you go to the East Coast, when I was in Michigan, there were women doing the same thing and more. They were some of those were trailblazers before me. I just
Mhm.
happened to be from a little small state. But that's it for that. And now after I did interventional cardiology for 16 years,
Mhm.
and I thought, well, I'm gonna let the younger people do that. And I
Mhm.
got something else to do. And so now I'm more focused on prevention, and
Mhm.
I see a lot of women with heart disease, but a lot of pregnant women with heart disease.
Mhm.
So
Oh, wow.
the
Yeah.
little niche now has been focused to cardio obstetrics. So
That's right. That's right.
Dr. K, you know, we all got little niches, and
Right. We
now
do.
we have started to develop one with the ACC, and that's cardio obstetrics, and that's something that's very dear to me now because
Mhm.
it starts early on when during pregnancy.
The American Heart Association is not only launching this year the Get Back Your Rhythm campaign, meaning telling us to talk about heart health and prevention, but they're also going to focus all year long and moving towards this inclusive conversation of reducing morbidity and mortality in pregnant women. And one of the issues is heart health in pregnant women. And we do have to start to build that into their discussion for heart health. I want to start to shape the conversation by having us watch a video about a woman who survived her heart attack. And some of these things can lead us into this conversation. You know, seeing is believing, and having a demonstration will help people say, oh, yeah, I remember a story like this. Or maybe, if this happens to me, this is what it looks like and feels like. And maybe I won't ignore some of these signs. Can we go to that, Dee?
I think, yeah, I think we are, our next guest is, looks like he has just got
Mhm. Okay.
into the room. So let's introduce him and then we'll go to the video.
Okay, great.
If we could, so while our producer's getting ready. So let's bring on Dr.
The
Bailey.
email
Hey,
from
Dr.
my cell
Bailey.
phone, you know.
Hey, Dr. Bailey.
Your R
Uh-oh.
Bail
Okay.
is BAIL and the
I
number
think he,
one.
Can you mute him?
I think he's still getting situated here. All right, so let
That's
me let me play this video. I can see if I can play this video.
It's like someone just took a massive rock and just hit me on my rib cage. My name is Cindy Mafu. I live in California. I am a mother of 2 toddlers and they keep me busy. I enjoy taking walks.
We're walking in the trails, we're walking in the woods.
Swimming. I love the beach. Don't ask me to get into the water in California, it's freezing. The day of the heart attack, it was a normal Saturday. I was doing my housework. Started mopping. And when I was mopping, I noticed I started sweating. And not just like small sweat, like profusely sweating. And I went and I washed my face. I came back, carried on with my work, and I started sweating again. I went back and I washed my face, and I thought this is odd because the cool air was going in the house. When I was washing my face, everything just seemed to be going black, and I called my husband because that's when I felt like I was very dizzy. He helped me to our room, and as I was trying to sit on the bed, I felt this crushing pain on my chest. I told my husband, oh, the pain, I'm feeling pain in my chest, and I was just holding my chest so tight. It felt like it was squeezing and everything was crushing. And then I felt the pain starting to go on my left arm, squeezing me tight. At that time, he called 911. In my mind, I was saying there's no way I'm having a heart attack. EMTs came. They asked if I suffered with panic attacks, if I had high blood pressure, if I was stressed. They asked me a whole lot of questions. They did an EKG and they said nothing was wrong with my heart. And because they gave me the option to stay home, I agreed and I stayed home. I laid down, and when I laid down, it felt like the pain was getting intense and more than what I was feeling. And my husband was like, I'm taking you to the ER. Because of COVID, I had to walk in by myself. I was checked into the ER. They started connecting me to monitors, giving me IVs and things like that. You could tell they now moving at a different pace. So in my mind already, I knew something was wrong, but I didn't know exactly what it was. A cardiologist came and she then confirmed that my blood work and the EKGs done at the hospital confirmed that I have in fact had a heart attack. When I was given the news, I just lost it. I was immediately prepped to go into theater so they could look at my arteries and my heart to see what was going on. And what was found is that I had a tear in my left descending artery, which is called the widowmaker. And I had a spasm and I had a blockage in my right artery. After I came back from the procedure, I was given a diagnosis that I have what is called spontaneous coronary artery dissection, which is known as SCAD.
A remarkable story.
Wow.
Remarkable. And it's remarkable from so many ways, even before we got into the diagnosis. And you asked this question, Dean, earlier was, why is it that Black women die? Heart disease affects both Black and white women, but we have certain things within getting to healthcare, getting to like an interventional cardiologist that come up, and these things can create, time is of the essence. From the time she started to feel this kind of dizziness, she was doing what moms do. I'm cleaning the house. I don't want to leave my house. I'm feeling bad. And what did she decide to do?
Stay home.
She wanted to stay down, and the dutiful husband, you got your beautiful kids looking at you, you know what I'm saying? So we think about this matriarch who says, I really don't want to go to the hospital, and making that decision, and that can cause some time. And so I think that, I think you've seen that, Dr. Nickens, where you asked a woman, what was the delay? What have you found to be the delay in seeking care, particularly for Black women?
Okay, that was typical, really, of the delay. When you remember her, she said that they asked her, did she have a history of anxiety? And I tell my residents all the time, let that be the last thing that you discover. Make sure that the person does not have any significant disease before you just assume that this is anxiety. Now, I hear some of my patients also say that the ambulance drivers ask them, do you want to go to the hospital? I don't think that they should ask that. I think they need to take them and let the physicians make the decision about what they've had. And you see, when I was listening to her story, the first thing that dropped in my mind was that she had SCAD because she's so young. I don't know how long after she had her children. I saw her children kind of small.
Right.
But spontaneous coronary dissections are not unusual. They are not unusual peripartum and during pregnancy. So I'm not sure how small they were, how long after pregnancy that occurred. That's a little different from the usual coronary artery disease. And I know, Dr. K, you're going to get into that. But it's not unusual to hear those stories.
Right.
And I've also heard ambulance drivers say they go and pick the lady up, and the lady got to go get her purse, got to go take a shower, got to go do all of this stuff before they actually get in the ambulance. So, from our standpoint, time is muscle, meaning you got to get that blood vessel open as quickly as you can. And if they are stalling, taking a long time to do it, and they're not knowing what's going on, some of them stay home until they start getting really sick. And then they go in. So the delay is within the person. There's also a delay in the medical personnel, and there's a delay in recognition of what's going on, a delay in, is this really cardiovascular disease? Why did that EKG not show a heart attack at first? Okay.
And that also is something that's very common. We're going to welcome to the show Dr. Ron Bailey. And
Thanks for having me.
how you doing, Dr.
Hi,
Bailey?
Dr.
Thank you
Bailey.
so
Doing
much.
wonderful, doing wonderful. Thanks for having me today.
Dr. Bailey is, speaking of Black History Month, and we want to make sure that we acknowledge his contribution to the field of medicine as well. He is the first Black chairman of a psychiatry department of the psychiatry department at LSU, correct?
That's correct.
And he is also a UTMB Galveston graduate from the medical school. Let me make sure I get it right. He also has connections to Meharry, as we all may have transverse there. So I interviewed there. I didn't get in, just by the way. But Dr. Bailey also led their psychiatry department. He's had so many appointments. He's also mainly noted too as well for being 113th president of the NMA. So we do thank him for his contribution to medicine and Black history. So it is both my privilege to have both of you, Dr. Bailey and Dr. Dickens, here. It really is special. So thank you for answering the call. We were just going over some of the delays that happen when a woman has symptoms of a heart attack, and talking about how the ambulance driver automatically said panic attacks, which again, whether you outside of the hospital or inside the hospital, I've had to teach my residents too, stop asking, is the woman emotional? And so, being a psychiatrist, you can tell us that one of the first things when we talk about vague symptoms, and heart disease can present vaguely, but one of the things that you as a psychiatrist have to do is what, Dr. Bailey, when we are trying to get at a diagnosis?
We've got to rule out medical first. So first of all, thank you for having me. I think Dr. K, you're 100% right. It's wonderful to be on your show, and I appreciate all of the good work you do for our community. As I jumped in, Dr. Nichols was making a point that she wants her residents and junior staff to, not overlook issues or think that perhaps it may not be organic and it may be psychiatry or psychiatric or anxiety. Those are exactly the same things that we in psychiatry share with all of our young people. In fact, all of our diagnoses are under a chassis, so to speak, that implies you should, rule out medical first. That's whether it's your heart, whether it's your lung, whether it's your kidney, whatever the case may be. What our struggles is not that folks should rule out medical first, is that once you rule out medical, you should also consider psychiatry. You should rule out medical and then forget about the fact that there are real issues. And if you do have anxiety or depression or panic attacks or whatever the case may be, those are functionally impairing actual illnesses. So the reality is both sides have to, I think, work together. And I love hearing this idea that we are, fostering and promulgating the same message.
You brought up there's another popular term we're floating around now called intersectionality, whereby we have people with who are on the margins of life who actually could have psychiatric issues and also have medical issues. And then so here we are, the cardiologist has to see the same patient that the psychiatrist has to see, and also I, as an anesthesiologist, may see if we have to go down and do something interventional, and then Dr. Nickens and I will be seeing each other again.
Yeah.
So when you think about when we're using this big phrase of cardiovascular disease, can you break that down for us, Dr. Nickens?
So cardiovascular disease is a big umbrella, and I explain this to most of our we've been doing these talks for over 20 years now, and the American Heart Association, and the Association of Black Cardiologists, as well as the ACC, have made it their business to try to increase awareness of heart disease among women. So when we talk about heart disease and it being a large umbrella, I have a little model here. I don't know if you guys can kind of see this. Our audience can kind of see this. But so if you consider this, these are little blood vessels on the heart, and then there's the muscle, that's the heart, but there's different chambers in the heart. Well, the main one that we're talking, the main cause of death is usually from these little blood vessels. When one of the blood vessels or the arteries, the coronary arteries, they get plugged up with plaque, get plugged up with blood clots to cause a decrease in blood supply to the muscle. So that's one kind, but there are other kinds that kids are born with. Some of them are born with problems with the blood vessels not connecting to the right chambers. And so those are congenital that's a congenital heart disease. But most of our adult patients, they have acquired heart disease. And that means that there's most of the time, something could have been done about it.
Mhm.
So there's a valvular problem, there's a muscle problem, there's a blood vessel problem, but just in general, we're talking about when
Mhm.
someone says a heart attack, we mean that one of those blood vessels
Mhm.
closed up and you had a decrease in blood flow to the heart.
You
That's
know,
the simple form of.
and you say we're talking about things like hypertensive disease.
Right. So something that could be prevented. Most of preventable diseases. So the risk factors, and I do give credit to our Framingham study, but after our Framingham study, there's been other studies, and I'm in Jackson, Mississippi. Our Jackson Heart study has also. We're looking at African Americans and what their risk factors are as well. But the Framingham study back in 1948 noted that anyone that were smokers, had hypertension, diabetes, a family history of heart disease, or hyperlipidemia, high cholesterol, those 5 things, they were at increased risk for heart disease. Now, later on, what we found some other things as well. We found that depression goes along with people that have depression, have the increased risk for heart disease. We found that patients that have preeclampsia when they're young. So a woman that has high blood pressure, protein in the urine, preeclampsia or toxemia, as they may think of it, when they have that, when they're in their 20s, by the time they're 40, they have an increased incidence for heart disease. So the risk factors are very important to note, and those are the preventable. Now you can't do anything about your family history, so that's the constant. But those other ones, we can kind of work those out and make some changes so that you don't acquire those other problems.
What about a congestive heart failure?
So congestive heart failure, and some of my patients say, I don't like that term. Failure, that means you got an F. Yeah, the heart is not doing what it's supposed to do. Okay, so it's failing to pump. The heart is really simple, really. And I tell the guys because they're used to cars. And so if we think about the heart like a motor, and there's valves in the motor, and so there's valves in the heart. If some of those valves don't work, then the heart starts to fail. If the muscle, because of high blood pressure, starts to fail, it starts to get weak, then that's another problem to cause heart failure. Now, there's a different set of symptoms for heart failure, and it's more of a chronic problem. There can be acute heart failure too, but generally ours is more chronic, and those are shortness of breath, leg swelling, have to sit up at night because they're short of breath. Patients with sleep apnea, they are have an increased incidence of having congestive heart failure. But valvular disease, the muscle problem with the heart, and high blood pressure leads to a lot of that. And high blood pressure can be controlled quite easily. You just gotta see your doctor.
Well, COVID has made us have some challenges. That's one thing she noted. If you noticed in that story, she said, because of COVID, the husband had to wait in the car, and so that could have also created some system challenges once she entered into the hospital. And that's quite frightening, and you also have patients who don't understand a lot of the information, let's say. So how has your institution been able to deal with that, or your patients face these challenges and have heart disease?
So we did not just the University of Mississippi Medical Center, but all across the country. Many of the cardiologists were seeing less heart attacks, and not because they weren't happening, it's because the patients weren't coming in. So by the time they came in, they're now with heart failure. Okay, so it was not recognized, or if they felt like they had shortness of breath, and the patients are afraid to go to the hospital because they thought they would get it from the hospital. So yes, COVID has impacted the cardiovascular world as well, and we all know the people that are the greatest risk for death were patients that have cardiovascular disease and some type of long-standing illness. But yeah, COVID has not helped. But I must say, I think I may have not gone in for 2 or 3 days. But for the most part, we went into the hospital and we kept seeing patients, despite the no vaccines at that in 2020.
That's right. Dean, you had a question?
I do. So if you're just joining us, we are here with Dr. K, Dr. Nichols, and Dr. Bailey. We're talking about Black women and heart health here on the last day of Heart Health Month. Dr. Bailey, I have a question for you, and Dr. Nichols alluded to, and we're talking about COVID and how people are experiencing more mental health issues as a result of the isolation, the indecision, the pandemic fatigue. That all of these things have been kind of dumped on us in the last 2.5, 3 years due to the pandemic. What is the interplay between a real mental issue and heart health?
Well, I think that the issues are overlapping, and the overlapping nature, I think, has grown. First and foremost, I think there's always been this diathesis between psychiatric health and clinical or medical health, what I consider, and very often there's a seesaw. If you're not doing well medically, you can get sad or depressed. You don't feel good because you're not able to run or work or enjoy social activities, or even your professional activities. And if you're doing well, doing poorly psychiatrically with depression and anxiety, and you're not eating, not sleeping well, what have you, that can worsen all forms, I think, of medical illness, or hypertension and diabetes and asthma and the like. In fact, the data would argue that really only rheumatoid arthritis is found less commonly in people with pretty substantial psychiatric illness. So our patients are more medically ill than the general American population. And I think that things have sort of got better in my 30-year career, that now you see all clinicians and all physicians much more aware of that. Early in my career, it was actually just the opposite. I think many physicians in all areas were just as bad as many lay people, and thinking that something was quote unquote all in your head, or you just have anxiety, or you don't really have a medical problem. So back then, I think the point Dr. Nichols makes very, very clear. Maybe the primary care physician wouldn't get the X-ray or get the EKG or do the full medical workup, because as soon as they got the patient with a psychiatric illness, that almost obviated or precluded the doctor from going through with a full medical assessment. To me, it's very similar to the unfortunate reality of the mistreatment very often of individuals based on race and ethnicity. Very good data that blacks get less catheterization, for example, even when you correct for SES status. So there have been other variables that clinicians of all forms and fashions have used to not give good quality healthcare to some. Very often it may have been about race, but they would also argue it has been about having psychiatric illness. That being said, I think that your point, Dr. Dean, is very, 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 very correct. The reality is we should be managing and being aware of and diagnosing and providing, I think, optimized interventions early on of people who are at highest risk. And African women are at a higher risk of many of these affective illness concerns, of mood disorders, major depression, than many others. The reality is they very often are the backbone of our society, in my opinion, is what I think of Black families. If a Black man goes to the doctor, is much more likely 70% of the time because a Black woman got him to go. His mother or his spouse or his wife or his daughter or whatever. So very often much of the healthcare in the Black community is dependent on and concentrated through, I think, the eyes and the efforts of Black women, whether it's for themselves or for the Black males, I think, in their family and their households. So for all those reasons, issues regarding having depression or anxiety or ongoing chronic psychiatric illness can have a remarkably adverse effect on health outcomes for the entire Black family and entire Black community.
Dr. Bailey, you brought up something that I was talking to Dr. Nichols about, and that's, walk down memory lane, and that's the Schulman study. And the Schulman study was done in 1999, and it's exactly what you were talking about, this referral to interventional cardiology and a life-saving procedure after you present with certain symptoms. And I'll have Dr. Nichols, do you remember that study in 1999?
I do remember it. Actually, I've used that information for lots of talks. And so what was done, this was a major study, and it was done with questionnaire. And at a conference that internal medicine, family medicine, surgeons, but for the most part, they were primary care physicians. And they asked them to fill out a questionnaire. They gave them 8 different people to review, and there were 4 men and and 4 women.
Mhm.
I'm pretty sure. Yeah. And so there were 4 blacks. And they all were actors. Okay. So,
Mhm.
but they all had similar backgrounds.
Story.
The description was the same. So for instance, there was a 65-year-old woman that presented with chest discomfort. They all had angina or chest discomfort, and so the physician was to work the patient up. Well, what was noted that women and blacks, these are white women and black women and black men, they got less worked up than the white men. So they had less catheterizations. Not that they had them at all, but this was a pretense. Would you send this patient for a heart catheterization, or would you do a stress test, or would you assume that this person did not have heart disease? So the black women and the white women, they tended to have less referrals for heart catheterizations. And that was in 1999. And so,
I'll just jump in. I think that, the term we use, psychiatry, I take a lot of credit. We have fancy terms for a lot of these things, but I think everybody does the exact same work. We call it being psychologically minded. And although that actually sounded very good early in my career, I think Dr. Nichols states it very articulately, is very often used to hurt people or to limit them in getting access. So the concept was, unless you were a patient who was psychologically minded, we in psychiatry couldn't give you the best forms of care. We could only hospitalize you or civilly commit you or, put you in restraint and maybe give you medication if we had that, but you weren't really able to receive, the highest forms of care, which is psychotherapy, individual and group, and the kind of things that only I think the high function people would actually receive. Right. The reality is, throughout my career, as I've read these stories and listened to what happens on the medical side of the aisle, as again, I think Dr. Nichols points out very articulately, really, they've done a lot of the same stuff. Found reasons to not give access to care, diagnostically, I think, or treatment interventions when there may be some demographic issue that's different. And I think all that is objectionable. Shows like today's, I think, are important to emphasize these issues so we can actually work to exclude them.
Well, we're using the fancy term of unconscious bias.
I was going to say, now we call it bias. Okay.
Unconscious bias. And then when you present it to them, they say, no, that's not what we meant. But the data, it was clear. And the reason we brought this up, not to get into, all the published data. Number one, there is published data on this, but we've been looking at these disparity issues since 1999. And if I'm not mistaken, this is getting ready to be over 20 years. We've been continuing to look at why disparities happen. And then we're starting to really now say, maybe we need to think about how medicine education is transforming good intentioned people. Maybe there's some way that we're interviewing our patients or allowing our students to interview patients. And it's also the way students are learning from older doctors, certain behavior patterns. And so that puts not only white students at risk for behaving a certain way when they when they see a Black woman, it also, puts Black students also behaving in a certain type of distance when they're presented with a patient. They're not really addressing hypertension or signs of congestive heart failure and saying, oh, they're fine, they're healthy. And that's just not a true statement. We've got to get more of an awareness of when Black women present, how they present. And one of the barriers is how we present in terms of communication. I think that's so big in terms of how we say we're hurting. And my question to Dr. Nichols, have you had odd abdominal pain as a presentation for MI?
Oh, yeah. So we see that quite often as well, and that's not new.
You mean myocardial infarction?
I'm sorry. Yes. Yeah, I'm sorry.
For our audience, you said MI. I'm like, MI? Okay.
Ellen, yeah, you need to keep us straight, right?
That's why I'm here. I represent the kids that sat in the back of the classroom. So y'all were up front, taking notes and doing what you need to do. I was sitting in the back of the classroom, so I'm helping them kids out and letting them know what y'all talking about. So
let me just say this though, because I see all color of people, okay? But the same thing happens with white women too, okay? Black women and white women. And I have to tell my residents all the time, okay, did you listen to her? Okay, did you examine her? And I'm telling them that physical examination is becoming a lost art, and listening to what they're saying is becoming a lost art. You just got to be patient. We got all these confused, but anyway, that's another excuse. But to get back to your question, yes, women do present differently, but the number one presenting symptom is chest discomfort, like the young lady on the film. That's still the number one presenting symptom is chest discomfort. However, if you're older, and even in older men, we have sometimes had 80-year-olds come in and they say they just don't feel good. I don't feel good, baby. And so you get an EKG and you see they got a big heart attack. Okay. So yeah, the age matters. Also whether they can tell you what's going on. So now we have different language barriers, and we have ways to get around that, but that makes a big difference. Culture barriers makes a big difference, but epigastric discomfort is a common problem. So it's right below the breastbone. They may feel nauseous, they may feel neck tightness, back discomfort, arm discomfort. I've had one of my patients, she never had chest discomfort. Actually, my dad had heart disease. And it took us about 4 or 5 years to figure out. I was a fellow when I realized that he was having angina. He was going to a physician, but you ask him, do you have any pain then? No, I don't have any pain. It was pressure. So I make sure I tell my resident, don't say pain. No, it's not. So that chest pressure that the young lady described is the most common presenting feature. But even my dad, he was walking. He said he had to go and park early to a restaurant so he could get in front, because when he came out of the restaurant, he was not going to be able to walk to the car because he was having chest discomfort. Because his belly was full, all the blood going to his belly, and so now he's having more angina.
But does angina mean you're having a heart attack, Dr. Nickens?
Ma'am?
Does angina mean you're having a heart attack?
So it doesn't mean you're having a heart attack, but it does mean that you're having a lack of blood supply to that muscle. So if you just stop and sit down and it goes away, we call that angina. Now, heart attack is when, like the young lady, that discomfort was still there, the blood vessel is closed, and you have more symptoms. And those symptoms can worsen. And 50% of the patients present with sudden death, meaning no one ever gets to them. They don't make it to the hospital. So myocardial infarction or heart attack is the most common cause of sudden death. But there are other causes of sudden death too.
Dr. Nickens, Dr. Bailey brought up a point about Black women. And we say, Black women typically are the CMO, the chief medical officers of their families. Do you find that because of that role that many Black women play in the family, they have a greater sense of responsibility to take care of the rest of the family, and in turn, that makes them take less care of themselves physically?
Okay, now, Ellis, I'm gonna just tell you this. The CMOs up here, they direct people what to do.
That's right.
Mothers and women are usually not CMOs. They are like managers.
Yes.
If you ever gone to the restaurant,
they got to do it.
You know who the manager in the restaurant is, because they picking trash up. They taking, ma'am, what you want. They bringing you to your seat. We're more like managers. So what happens is they're serving you. What you want for dinner? Oh no, I don't want that. Where do I need to go drop you off? So the mama got to take them, bring them, go to, they're doing a lot of different chores. And so they're ignoring themselves.
Yes.
Yeah.
I would love to be a CMO, but I'm
Dr. Bailey,
more like a manager.
Dr. Bailey, I want you to chime in here and talk to us more. Have you heard of this? They said that John Henry used to be like the theory behind hypertension, and the way you work so hard. Have you heard of that term before?
I haven't. And before I get to that, I just also add to an earlier point that was being made. I point out that, early in my career, we did a study. I was in UT Houston at Harris County Psych Center, and we recognized, and it's certainly not rocket science, that some patients, I think, because of the so-called white coat phenomenon, were really afraid to ask questions to
Yeah,
the
white
doctor.
coat phenomenon.
So
That's another
some
thing.
groups, I think we have to kind of teach our doctors, young and middle career, so to speak, that you don't just ask a patient after you've spent some time giving them a narrative. Do you understand? Many patients, maybe African American women, may out of the kindness of their heart or the lack of feeling the empowerment internally to ask a question, let alone seemingly challenge the doctor, and that entire imbalance of power, doctor-patient exchange. So we got to teach our doctors to have the patient say back to the doctor what you think you said to them, to make sure before they walk out of the office that they've actually heard correctly, and theoretically, A, they can follow the recommendations. B, maybe if they'll know what to do if you get from point A to point B. Very often there's some questions to be answered between the next visit. And see, most importantly, if they disagree with it, that they'll feel empowered to tell you why that's not going to work or what the disagreement is. I love the point, this idea that I think as I talked to a father, he would say no, he didn't have any pain when he was having what he considered pressure. That's the doctor's job, to ask a better question and elicit the information accurately. So I want to squeeze that in. But to your point, the idea I think about how pressure, Dr. K, adversely affects, I think, our ability to that point to engage in a doctor-patient exchange is real. I mean, our data makes it very clear that psychiatric problems very often follow some of the initial conflict. It's interpersonal conflict that can occur between families, between spouses, between parents and kids, and between a doctor and a patient. So when that conflict occurs, it may not always lead to people putting their dukes up and fighting or whatever, but it definitely leads to an ambient, poor communication exchange. And very often for patients, I think, who don't have a secondary aspect, if you're not going to go home, and there's a doctor at home with you, if your relative is in a doctor, you can all ask the second and third question. You're going to get you're going to have an inferior communication with a doctor, and the information that you needed to receive, you're not going to receive it optimally. Those are exactly, I think, a lot of the metrics that have led to bad outcomes for African American patients, in this case, African American women, I think, for a long time. So we got to do better in that regard. And I love the point that you made earlier, I think, Dr. K. The reality is we got to teach all doctors, not just African American doctors, to think this way. The reality is more African American, although African Americans are much more likely to pick a black doctor than not. They used to be 5 or 6 times, because there's just so many more doctors who are not African American than otherwise, more human beings who are African American who go see a doctor that's not black than otherwise. So the truth is, all doctors should be mindful of, to address health disparities, these issues that I think are unique to the black patient.
When you back down to hypertension and the sister, I'm getting to the issue of stress on the patient. And they used to historically call it John Henryism or something. John Henry worked on the railroad. He was always under stress, and he was in the heat. And so they taught this as the reason or etiology for high blood pressure. If you go back through some of the medical history articles. But what are we seeing now in terms of, especially in New Orleans, in terms of that connection between stress and high blood pressure and heart disease?
Well, the stress deficit is a vicious cycle. I get grand rounds at LSU and Austin just last Thursday, and we were speaking about stress and the impact, I think, on communities that's addressing, the whole violence phenomenon. That's unfortunately another huge dynamic that's unfortunate in our society. But you're right, as I mentioned earlier, I think the issue regarding stress and anxiety is duplicative. First, it could be an initial problem. Many patients have what we call a GAD, or a generalized anxiety disorder. You still function, you still go to work and have your family and drive your car, but you're kind of always hypervigilant, always a little bit on edge, always a little bit more antsy than you theoretically should be. People kind of get by with that, and in your life and your family and at your job, your relatives and coworkers learn to engage with you, but it creates a chronic drain on your particularly your primary heart and pulmonary systems. So those systems are, I think, under a greater degree of pressure, like they're kind of carrying an extra weight to function, I think, in your normative fashion. If on top of that, because of stress, you eat too much and you have some obesity, or you smoke too much, because for some people, smoking lowers their anxiety, or you engage in other activities that I think very often are detrimental to your health. I think exactly right, Dr. K. It's a vicious cycle. It's a combination of variables that I think put you at a greater degree of risk. That's why when you get to be this in your 4th and 5th and 6th decade, if you're late 30s and 40 and 50 years of age, or 60 years of age, 7th decade, these risks, I think, of MIs or heart attacks are greater than in groups of persons who, during that period, we were actually engaging them in more positive, proactive activities to modify and limit stress and not put them at a higher degree of risk of an MI.
Can you tell us also, I'm sorry, Dr. Nichols, go ahead.
One thing I want to say about the John Henry syndrome, I don't know a whole lot about it, but I do know that when people work out in the sun and work outside, I had some relatives that were taking salt tablets, and so now we've changed from salt tablets to salty drinks.
Right.
And so we're seeing that in our football players early on. So our kids are getting hypertension early. I think that we just have to consider all variables of what they are doing that's modifiable. And so it's not just the genetic part. Part of it is genetics, but part of it is what we are consuming as well.
I'd also add, it's hard to be psychiatrist on any kind of program and talk about stress without emphasizing why this is such a complicating factor, I think, in our community. For so many people, and culturally, it's pretty not acceptable to say that you can't handle it. So persons can wear a big badge of honor, being the one that can manage a family that's having trouble and a kid that's having health problems and a grandmother that has, dementia and a house that had a hurricane in New Orleans or burned down, or the case may be, all kinds of issues, job troubles, boss troubles. But as somebody ask you, your father, did he have pain? He said, no, I'm fine. But if you also ask somebody how they're doing, they all say, I'm good. Everybody's, I'm good. I'm good. And I don't know where it came from, but it's I'm good. It's just got to take it over. The person sitting in my life, in my office, and I'm looking at this paperwork where all these things that these stresses they actually have written down. But when you ask them, I'm good, it's become a knee-jerk response. So again, get back to what the doctor has to do. We've got to be better than that.
Yeah.
And better than this construct of allowing partial communication to walk out of our door. It's my job to find out how really are you feeling and what really was bothering you. How are the defense strategies you're engaging? How are they working? Or are they working at all? Once you begin to get to the limit of your defenses, whether it's going to church and praying on Sunday, whether you exercise, whether you crochet, whether you do X, Y, Z. When you get to the point where you've exhausted your defense mechanisms, we've got to kind of find some strategies to help you so that you don't go over the top. And very often over the top is that MI or that heart attack.
Dr. Bailey, you eloquently described anxiety. Can you give us our definition of depression? Because a lot of people may be experiencing it this as we reemerge from COVID, but like the American Heart Association says, they want us to find our rhythm again. They want us to, get back into the routine. They want us to start going back to doctors. They want us to get some fresh air. They want us to find some good food. But maybe the reason that it's not happening for someone is that they really are clinically depressed. And if you could describe that in case someone is listening so that they can understand what they need to do or address it.
Right. So for me, the 5 areas that we consider that people should know about and should talk about begin with the so-called vegetative symptoms, sleep and energy and appetite, things that you can very often see, touch, and feel. Next, they move to cognitive symptoms, how you think, concentration or memory or attention span, ability to stay on task. Maybe the second area, very often in order, that you begin to have problems with. Third, very often we describe episodes of despair, feelings of hopelessness and helplessness and worthlessness or guilt. In old days, we call it melancholy. That a person will have to tell you, we won't really see it, though we can't show those initial concerns. Those are really the big 3. Probably the fourth area, which is huge, is somebody got where they were psychotic. They just were not able to function within a normal realm of adult life. And of course, the fifth and final area is violence. Very often, violence turned inward, we call suicide. So vegetative symptoms, your body, cognitive symptoms, your thinking, emotional symptoms, despair, then psychotic, and then suicidal concerns. I think the big issue very often is when somebody has some of those early ones, very often they try to treat it on their own. We can't sleep by drinking alcohol. We can't think clearly, whatever, so we think we're going to smoke a cigarette, kind of perk up. So many individuals are doing a variety of activities, their own self-medicating, if you will, trying to address these early signs of an initial onset of depression. They ask us, well, do you meet the criteria? Well, once you've actually had some of those symptoms, you met the symptom piece. But the other aspect of getting a full diagnosis of major depressive disorder is you also have to have functional compromise. So for me, it's in 2 key areas of your life, something that you used to could do normally, you're not. Maybe you have trouble on your job, or trouble in your relationship. Maybe you're driving so fast now you got arrested. drinking so much now you got a DWI. Maybe that's some kind of a health problem. But very often something has happened where you're not able to modify or compensate as well now as you did in the past, and it begins to come out. Maybe you get isolate. You don't go bowling on Tuesday nights. Maybe you lose your friends and your engagement. Maybe you stop eating and you actually do lose weight. But people very often know it, but they're trying to hide it or ignore it. Others may want to say it to them. Sometimes if we're too close to somebody, if they're a very good friend of ours, we don't want to say it. We push people to say, close the door and have that difficult conversation with your relative or your friend or your brother, your coworker, saying, this just isn't working very well. We can see you having this type of trouble. Everybody can see it. You really need to go and get some professional help.
So it is, like you said, we have noticed an increase in smoking and maladaptive behaviors during COVID, which of course may not present to you as a psychiatrist first, but actually may end up presenting to the emergency room as chest pain and discomfort, and then have Dr. Nickens and her team come down and take a look and have to sort it out, right? Are you seeing an increase in these type of problems where increased smoking and alcohol can cause some chest discomfort, Dr. Nickens?
Yeah, we are seeing that, and not just that. We're seeing an increase in vaping and marijuana use, and here, because we are a big referral center, we also are seeing a lot of drug use as well. So we're seeing it, and we're asking. Lots of people have not gone back to church, and the African American community, the church has been one of the main key that we could go to and sort of iron out some problems, but many of our churches have not resumed, and I think that worsens things. But yeah, we have seen all of the above.
Well, I'm going to say some preventive strategies, and then we'll have our little preventive pick-me-up video. But I want to say that American Heart Association is recommending, of course, that we get 150 hours of exercise for the week, and that's 30 minutes a day, 5 days a week. And as health disparity, conversations, as we keep talking about this, we know that some communities that's very difficult. Lack of playgrounds, lack of access to lighting in communities, that's a challenge. But we would ideally, in a perfect world, we want to strive for that. Some people have stopped again going to the gym just because they don't feel safe due to COVID. Healthy fruits and vegetables. It's a challenge, but we definitely all have to eat better. I know when I go to New Orleans, Dr. Bailey, I can't help myself. I'm going to have my beignets. I'm going to have some fried chicken. I'm going to have my Dr. Nickens, I'm going to have a biscuit when I'm in Mississippi or Georgia. It's going to happen, okay? Yeah. If I can get me some root beer, that's going to happen too. So Atlanta, you already know, and the ATL is up with my eat on.
Busy bee.
We're not perfect, but we do want to issue what we know to be true that leads us to a healthy lifestyle, and we all can try again. So I had teed up my man, my executive, video guy made a nice video, so I wanted to share it with you. It inspires me to get going. And then we can just, kind of wrap it up. What do you think? So that's
That was
one of
good.
my favorite.
I
favorite
love it.
That time.
he actually
real
made
good.
my breast cancer videos. Junkyard Cinema, John Kalo, he's excellent. He's out of Philly. But I love this because it encourages us to keep moving. It shows a Black sister getting down, getting her workout on, and she's not in the gym. So if you gotta, use the streets to work out, do it. You gotta use a football field, do it, and that's really for everybody. We have to keep moving, breathe. That's going to help us psychologically and physically. And I just really thank everybody for being on the panel. I want to end up with any last comments with Dr. Nickens and Dr. Bailey.
We've been doing this for quite some time, and we just have to keep encouraging our patients and encouraging our families. My families hate to see me coming, and so we have to do it ourselves. If we're not examples, they're not gonna believe in what we're doing. And so, it's just a lifestyle change, and it's seen in Black women, Black men, white women. It's a big problem all over our country, but we just have to keep encouraging. One thing I would like to say, if you guys can promote everyone to get a blood pressure cuff in their homes, everyone. So I asked so you would say, oh, they can't buy that. They don't have any money. So let me tell you, I asked my patient, hey, how many televisions you got? And calmly, they happy to say, hey, I got 3 TVs. Okay, then you can afford a blood pressure cuff.
And they have a phone. You can download
a phone. They might not have a home, but they got a phone.
Well, let me tell you, you can download it, and you can also do smart blood pressure apps, and that way you can record it, and that does help your cardiologist. The Black Cardiology Nurses Association, they want us to be able to record our blood pressures on a regular basis and take them into the doctor, because it's not just one number, it's a trend, right, Dr. Nickens?
Exactly.
And a pulse oximeter too. That's right, for the rate. Thank you very much for that comment. Dr. Bailey?
I'd say I love this axiom of 10, 30, 60, all percents. I teach in forensic psychiatry. I've quite been testifying in my career. If you testify, you want the jury to remember what you've actually stated. If you said one time, they're more likely to remember it 10%. 2 times about 30%, 3 times about 60%. So about half the jury will remember what you said at all if you get it out of your mouth 3 times. So the reality is, in good clinical medicine, we probably could take a page out of the forensic textbook. Repetitive messaging matters. We're making some arguments that I think are essential for people's lives. They need to hear it. I think I said it earlier, but I said it again. I think educational programs like what you're having, Dr. K and Dr. Dean, I think are just imperative and important for us to get a message out that's so important, I think, for our community. And I think a message that I think is very proactive. I'm particularly interested in what young people think, and we get them on the right track early on. Children, but definitely teens and young adults, develop good, positive, health-oriented activities that I think are proactive and help move in the right direction. So often, part of the struggle has been because of the thought of lack of resources. Many African Americans didn't have resources or money or health insurance or access to whatever. In many regards, when that's not the case, the decision we make on our own may limit our ability to receive optimized health outcomes. Our goal has to be to improve those outcomes, to decrease, as you said at the very beginning, adverse health disparity. So thanks for having me. And I think we should continue this pro-educational movement.
All right.
Thank you.
That was fantastic. Just for me, and then Dr. K, you can wrap up the show. But for me, I would say when you're trying to eat healthy, shop the perimeter, right? If you notice in your grocery stores, there's going to be your healthiest foods are going to be on the outside. Your most unhealthy foods are going to be on the inside in those aisles. So shop the perimeter of your grocery store. Eat the rainbow. That's another thing that you can do do multiple times. That's eating a lot of fresh fruits and vegetables, different colors. They give you all those nutrients to help your heart, because eating a more plant-based diet has shown to be healthier for a lot of conditions, diabetes, hypertension, and that all helps your heart health. So I would say do that. We just saw the video that made us all tired. Watch it. You gotta
make us want to go and work out.
Make you want to go work out, but you gotta move.
And listen, I know I'm through, but I've got to squeeze this in since you mentioned plant-based. I'm in a group of a cohort of about 50 African-American physicians. I give credit to the guy that leads it. He's a urologist out of Nashville, Kevin Billups. I started October 1st. I'm down 27 pounds in 4 months.
Oh,
Plant-based. Plant-based.
Just
Plant-based
plant-
It
diet.
absolutely
Brandon,
is,
we were
is a
going to
good
go back
thing
to
to
that
do.
Jamaican restaurant. So we can eggs and cabbage.
Well, I'm not perfect. This guy's good. They talk about cheat days. There's a lot of cheat days.
There's
I
a lot of
probably
cheat
got
days.
40 pounds if I did it solely, but it definitely helps. Plant-based, Ellis is right, is absolutely, I think, a good thing for us to consider.
That's right. Well, let me just say, once you said that, an accountability partner is important.
Yes.
Making SMART goals is important. That's specific, measurable, attainable, and time-sensitive goals. Like Dr. Bailey, you have this group. You have a support group. Y'all are specific about what you're going to do together. Johnson & Johnson wellness programs always have advocated that we create SMART goals in order to accomplish it. And finally, the last thing I want to say is people need to know their numbers. You need to know your blood pressure number, if it's changing over time. You need to address it with your doctors. You need to know your heart rate. Someone said your pulse ox. Yes, we do need to have a pulse ox, and that's going to tell you sometimes your heart rhythm. Your phone will also pick that up, or you have these smartwatches that pick it up. The other thing is we need to know how much we weigh. So again, people say, "Oh, I'm not getting bigger. I'm wearing the same size clothes, but how does it fit?" And that's not vanity, that's a reality. And if you look at different programs, they say if you don't, like the obesity code, they're advocating sometimes fasting and trying to miss a meal. And they found that people can reduce to 2 meals once a week, can limit their weight gain over the year. So check out your trend, have a scale in the house. Don't be ashamed to get on it. You don't have to tell anybody. It doesn't need to be on Facebook, Instagram Live, or Twitter, how much you weigh. And just deal with the reality one day at a time. And that's all you can do is take care of yourself, advocate for other people.
Give yourself some grace.
Give yourself
Please.
some grace.
Please give yourself some
And
grace.
look, when you support other communities, we can do this. But as someone who's passionate about health disparity, we have to advocate for those communities that can't, who don't have it. And so as we emerge, please volunteer over the spring and the summer. Get out with the youth. They will encourage you to exercise, walk, talk with other parents about their struggle. And like Dr. Bailey said, maybe you'll find out everybody has a message of empowerment and hope. So I want to thank you, Dean, for having me host. And it was a pleasure with two of my good friends, Dr. Nickens and Dr. Bailey. I really appreciate it. It's been an honor, and happy Black History Month. And go red.
Go red all year now. Not just this, not the last
Go
day.
red
Go
all
red
year.
all year.
Look, and
Tomorrow-
Black History is not just this month. We also have Black History with the first nominee, Black female to be nominated and
Yes.
going to be appointed to the bench. So there we have it. We still making first.
Yeah.
And she will make Women's History Month, which is March. That's Women's History Month.
That's
if you need some help moving, here on blackdoctor.org, every Monday, every morning at 8 a.m., we have a fitness. You can do it in your home, in your living room. Just pull up blackdoctor.org. You can watch it for 30 minutes, Elena Fitness, and that'll get your 30 minutes. 5 days a week. We got Elena on Monday, Wednesday, Friday, and we've got Fitness Snob on Tuesday and Thursday. And then on Thursday evening, we have Veganish, which is our program about how to eat a more plant-based diet. And so that is 8 p.m. every Thursday. So we've got programming here, as well as the articles we have on blackdoctor.org that can help you on your journey. Again, Dr. K, you are wonderful. That's why we call you Special K. Dr. Nickens, Dr. Bailey.
The best.
All right. I appreciate y'all.
Guys.
We'll see you soon. We'll meet up.
Yeah, I had a good time.
Thank you. God bless, and we'll talk.
All right.
Bye-bye.
Bye.